Welcome to this neonatal occupational therapy webinar, which is for enhanced level practitioners. My name is Beverley Hicks, and I am a developmental specialist and neonatal occupational therapist working at University College London Hospital. And with me is Amanda Clifford.
Hi everyone, my name is Amanda Clifford. I am an occupational therapist also working for the Thames Valley Wessex Neonatal ODN and shortly at Chelsea Westminster Hospital.
This is part a collaboration between the Royal College of Occupational Therapy and Health Education England, and it's part of a collaboration to work on developing the future AHP workforce, particularly for neonatal therapists. And it's part of a wider blended learning programme that includes an in-person workshop, one which will happen in London in February and another in April in Leeds. Today we're going to talk about neonatal frameworks and their application to practice. We're going to think about what all of these terms are, and outlined on the screen are the ones that we're going to start thinking about what it is and what it might mean for you as a neonatal occupational therapist on the unit, particularly if you don't have a full-time post on the unit. So how do these relate to OT practice and what your role might be in them? By the end of this webinar, we hope that you'll have some awareness and understanding of the current frameworks and jargon that is used on the units, to think about how relevant they are to your neonatal OT practice and how you can be involved within these frameworks and models on your own neonatal unit. There are so many words in the world of neonates: family-centered care, baby-friendly or BFI, family integrated care, developmental care, NIDCAP, FiCare, or family integrated care, IFCDC, FINE, Bliss Baby Charter. All of these words and all of them have different meanings, connotations, and different parts of it. So we're going to start off thinking about developmental care at the beginning. If we think about developmental care, this is the provision of sensitive, individualized caregiving to infants on the neonatal unit. And the aim of this is to support brain development, to provide appropriate sensory experience, and make sure that parents are at the heart of their baby's care. As Daniel Stern has said, the infant comes into the world bringing formidable capabilities to establish human relatedness. Immediately, he is a partner in shaping his first and foremost relationships. And it's from work like Daniel Stern and Winnicott and Brazelton that we've really found out about the unique capabilities of the individual infant. And this is one of the reasons why developmental care needs to be so individualized. However, I'm going to suggest that developmental care is a much more generic program, and we should be thinking about using IFCDC, Infant and Family-Centered Developmental Care, which is a bit more of a mouthful, but it is thinking about individualized care. With generic developmental care, there's a collection of strategies, and it's all about improving comfort for all, which is really good. So we can think about having protocols for light or for sound, for thinking about when a baby can come out for kangaroo care. You need knowledge and you need to have commitment, but it doesn't necessarily mean that each person is very specialist or skilled at assessing the individual needs of the baby. And the quality control can be very varied. There are possible to do benchmarks or audits, but it actually doesn't look at that individual care for the infant. If we think about individualizing it, we're thinking about using reflection on our practice, individualizing based on observations of the baby, and it uses advanced behavioral observation and analysis skills, and programs such as the EFCNI standards and NIDCAP have very rigorous quality controls as well that you need to meet to ensure that you're providing sensitive caregiving. The European Foundation for Care of the Newborn Infant, or EFCNI, brought together a very large group of the top researchers and practitioners in the world of neonates across Europe and the Scandinavian countries, and they created the European Standards of Care for Newborn Health. These are a fantastic resource which I would definitely recommend you go to. There is in particular a standard on developmental care, and there's a standard on education and training. Both of these are really quite pivotal to understand, and the UK was actually part of writing those when we were still part of Europe. And for some countries, these have been adopted at a parliamentary level. So for instance, in Belgium, it is the expectation that all neonatal units will actually be following these standards. So across Europe, these are very uniform, and it means that we can think about our care. And they are very worth reading and keeping up to date with. Some of them are being revised as we speak. Then we think as well about other models that we're going to use to think about how we individualize caregiving. You may hear the word NIDCAP, which is the Newborn Individualized Developmental Care and Assessment Program. This is an advanced training program that takes approximately 2 years to complete. It has a very high level of quality control with regular recertification to ensure that you're meeting the standards. And it fits so very well with occupational therapists because it's based on detailed observation and analysis of preterm behavior as part of a problem-solving process. So we think about what the baby is telling us and how we can work with their strengths and challenges and adapt their cares. And we do have an NIDCAP training centre, which is based at UCLH. However, NIDCAP is very time-consuming and it is expensive, and it is a highly specialist program that is not necessarily suitable for when you're first starting out in working in neonates. So you probably have heard the word FINE, which stands for Family and Infant Neurodevelopmental Education. This is a program that provides different levels of training, which build up to the 4th or specialist stage, which is NIDCAP. It's the creation of Dr. Inga Warren, who's an occupational therapist, and her colleagues in Rotterdam. And in this photo, we can see Inga receiving her award from Prince William as she was named in the New Year's Honours last year, which was a fantastic recognition of her work with preterm infants across not only the UK, but across the world. She does a large amount of work in a lot of the Eastern European countries at the moment, bringing developmental care there. So you may have already done, and it is a good idea to think about doing, the FINE Level 1 training. This is a high quality evidence-based program. It's run across the world. It's now translated into over 27 languages. It is based on the NIDCAP principles, so therefore it aligns with the standards, the European standards as well. And it teaches sensitive caregiving. It opens your eyes to the evidence base and how you can provide caregiving that is sensitive to the needs and appropriate to the needs of the individual infants. So how does OT fit in with these sort of conceptual models, these models that would underpin our practice? It would make us understand what the baby is needing and what the family is needing. So I think very much it's understanding the evidence base behind the IFCDC, thinking about individualizing caregiving. So there are benefits to both the universal and individualized approaches, and this is going to depend on how many hours you have on the unit and what your unit actually puts their emphasis on. It also thinks about utilizing the MDT in universal work. So thinking about champions for the different aspects. You may have champions for skin to skin or for positioning or for any aspect of the care. It also helps by using frameworks like this, we can look and spend time assessing the individual baby's person factors and environmental factors and see how these impact on occupational performance. So we can look at what the baby likes and dislikes and their strengths and their compromises and how we can modify the physical environment. It also is important that when we are contributing to unit guidelines and we're network developmental care guidelines, that we know these and that we're on the team for regular review. So for instance, once again, pain and stress management or skin to skin. And this is a role that the OT, it's quite vital, it's quite helpful to be part of that multidisciplinary team looking at your network-wide or your unit-wide guidelines and making sure that we're thinking about the individualized care and providing that for them. But now we're going to think about some of the frameworks that aim to support babies and families on the units.
Okay, everyone, we're going to launch into FiCare, and you might have heard of this. Well, I'm hoping you've heard of this if you're working in the NICU. FiCare is a concept which goes above developmental care in that the primary aim of it is to have parents as partners, and that's really important difference. So it's about enabling and empowering and connecting families to be a part of the team. The parents are seen as the primary caregivers, and as you can imagine, that is a very big culture shift for many units to actually go down this way. It originally came from a study that was done in Estonia, which sort of essentially showed that when they had a low staffing levels, when they had parents coming in as primary caregivers and they were integrating these parents into everyday activities, that actually the length of stay decreased and there were increases in weight gain for these newborns. This was then developed by a team in Toronto, Canada, and is now recognised in the UK through BAPM. And they've adopted this model, and they've actually expanded it to what's become their BAPM framework for practice that you can see right there. So I'll take you through a few of the pillars so you can get a bit of understanding of how it actually works. Sorry, guys, I'll go back one. We'll start here, actually. The partnership first aspect is actually what it says. So we're talking about families seen as equal members of the team. So that includes things like on ward rounds, daily care planning, and absolutely shared decision-making. And the family's experiences and feedback are sought at the beginning. They're not sought at the end. They're actually done that at the beginning so they can inform and change practice and improve quality of services from the bottom up. It's looking at things like having steering groups that comprise families within that capacity, parent advisory groups, and the members of the MDT are established with those parents and to drive improvements forward. When it comes to empowerment, we're talking about that families have access early on to the orientation onto the unit, that they've got structured and individualized education that supports their confidence and their knowledge and the tools to engage with their advocate for their baby's needs. We're talking about things like offering families activities, classes that are inconvenient times for them, not for the actual staff on the unit necessarily. And that includes weekends and evenings, and there's opportunities for peer-to-peer support learning. When it comes to well-being, we're talking about both the family and the staff's well-being, and both are treated with just as much importance. That they've got access to psychological care, peer support, education. We've got things like positive workspaces, psychological support, and collaborative team building. And when we go further into that, we're talking about making sure there's consistent family access when transferring between units in repatriation, and that wellbeing activities are offered to all families and staff. And this could be even things like yoga and crafting and meditation. When we come into culture, we're talking about shared collaborative culture. So it's promoting family integration in care delivery and empowers staff to implement FiCare and actually enjoy the process. We're looking at things like building in staff orientation and annual skills updates, FiCare education and training, so that everybody gets an opportunity to understand what it is and then how to actually act that out on a day-to-day basis. When it comes to environment, what we're looking at, of course, is physical environment, but also the social environment, that both are friendly and comfortable and provide 24 access to families to be with their babies. And this is gold standard. And I know this doesn't always happen on units and it's a work in progress, but this is something to attain for. It's inclusive of rounds, and it minimizes the separation between mother and infant and enhances experiences of care. Things you could do, things like cot-side environment, looking with reclining chairs and breastfeeding pumps, things around making sure there's dedicated rooms for parents to actually, there you go, the chart, next bit, to actually look at expressing milk in comfort and have privacy, and things like having even things like, on-site childcare, potentially play therapists, they're ideals, but would be lovely, and that's the kind of premise we're looking at. So we're basically saying that we would like the environment to fit the family, not the family to fit the environment, which is quite different to things that we've been doing before. Okay. Oh, sorry, guys. So when we're talking about FiCare here, what we're talking about is promoting and facilitating a champion of parents in their presence and their participation in the care of their babies, the primary caregivers. The goal is to help parents to form close bonds with their baby and to leave the NICU sooner. The nurses and the AHPs and other staff understand the unique needs of that infant, knowing they are unique, and can teach and coach parents to understand and help their babies. And I think that actually it says teach here, but it really is coaching. It's not about providing instructions, it's about walking with them in the journey. And as parents learn, they feel more confident in their caring, and by the time they go to another hospital or discharge home, that basically we're looking at making sure that family is actually feeling like they are confident in understanding the needs of their baby and taking care of their infant. Okay. So if we go one more. How does OT fit in? Well, OT is key in fitting into FiCare. We know when we're looking at OT, we're looking at the whole person, aren't we? And we know in the NICU, we're looking at both that baby and that family. So what we need to be doing as occupational therapists is making sure we're advocating, modeling what it is to partner with family. And that's really important. We're talking about coaching and facilitating. We're not talking about telling and doing for them. We're doing things with them, not to them. We're looking at potentially looking at maybe cross week or after hours working, which I know is not kosher for OTs, but maybe this is something we can think about doing, and certainly being flexible with that to actually access all members of the family. Parent and staff education to get in there early is great. Seeking feedback is a very important part to how we could do as OTs, and making sure that we're getting feedback and building things from the bottom up as they're developing, having parents involved at the beginning of a new project rather than at the end giving feedback. Making sure you're a part of the FiCare MDT group, because I think it's really important, and Bev and I will both say this, that when we're looking at becoming onto the unit as an OT, we don't do things in silos. And in fact, trying to do things in silos is very challenging. And we're looking at a lot of change management when it comes to FiCare. We're looking at making changes on the ground up. So being part of the FiCare MDT group has two purposes. Firstly, it means that you actually are with like-minded people. You can actually work on activities which are bigger than just ourselves. And because we often have very limited time on the unit, this actually gives a lot more opportunity to make some really big changes quickly. So things like you can get involved with repatriation projects. We've got something in our Thames Valley Wessex ODM with the parent cards that we're working on. Getting involved in a network level is really important. There already things are going on outside of your unit, so have a look at that too, because that will influence where you were at. Developmental care ward rounds to be developed, peer support and psychological support groups. And don't forget, as OTs, we are loving our mental health skills. So utilize them, don't just think physical. Okay. So we're moving on to the Bliss Baby Charter, which you might have heard of. And essentially, the Bliss Baby Charter is slightly different. So this basically is the same concept, placing families in the center of their care. So it's family-centered care versus family integrated care. They are different things. And we have a look at this process, and it really is an audit process that actual units go through. It's practical in the framework, and essentially units can assess themselves against themselves. So there's a accreditation, lasts for 3 years, and you aim for your platinum status at the very end of that. It is a process. But it looks at protocols and at resources, and therefore doesn't necessarily look at the quality and sensitivity of caregiving, which is slightly different. Let's explain a bit further. So it aims to ensure parents are centered their baby's care and improving consistency of care and support to babies and families. So it's looking at the developmental care for babies. What are the acts? What are we doing with this baby? How the parent actually involved in the care for that baby? And it's essentially making sure that baby receives the clinical developmental support and care that they require to their individual needs. So 7 Bliss Baby Charter principles are, as you can see, social and developmental needs. So when we're looking at that kind of thing is like parental access, looking at their sensory needs, their touch, light, sound, taste, smell. It's about guidelines, equipment. We can do this on a big scale in terms of actual unit projects and universal work, or we can do this on an individual scale as well. When we're looking at decision making, that's making sure that families are around in care plans at the beginning of the day. We could be looking at ward rounds and making sure there's psychological support on the unit. Specialist services and staff are what it says, having AHPs that are available, and not just available, timely available access, which we know is always challenging, and the referral pathways are clear and succinct. That there is skill competency across the unit, and that across the network as well, in terms of having guidelines which actually outline what all units should be aspiring to, and to manage that way. In terms of benchmarking, seeking that parent voice is still important, and actually having parents included in those improvements is also a part for that. When we talk about unit information, that's the basic things. What are the welcoming packs? How do families actually know how to, access the car parking? How do they know where to go to the toilet? All those kind of things, which are really basic things, but very important for families to have that succinct information when they're at a time of considerable stress. Things like making sure that people are introducing themselves to parents and explaining their role, which I think for OT, we need to get really good at doing that. What is our role and how can we actually do that really well? And explain that succinctly and so people understand in the concept of occupation. We're looking at making sure in terms of feeding that BFI accreditation has started, which we'll talk about in just a second. We're looking at equipment facilities and making sure there is skin to skin happening, that there is an expressing room, and actually there is equipment to be able to do that for families. And that they are supported through that transition from a tube feed to breastfeed or bottle feed, and that people are understanding what feeding cues are and families can understand how this works. And then lastly, discharge, and that's looking at MDT involvement, making sure that parent is confident in caring for their baby's needs before they go home, and that they actually have follow-up services which are going to be seamlessly, in theory, hopefully, attended to as they actually leave for hospital for the next thing for their home. Okay, I'll really quickly jump through the audit process. This is just so you're aware. You don't necessarily have to worry about this kind of thing. It is a whole team approach, and this is often led by much higher up than what we are doing at MDT. We can be a part of it and acknowledge it, but this is just so you understand how this works. You've got your self-audit, you've got a pledge of improvement which goes through, and you can get your certificate, you get RAG rated, you develop action plans, and Bliss gives you feedback as how that's going to go. Then you move on to your bronze, and the bronze section there is when the action plans have been implemented successfully, and you do a second audit where you go back and find out if anything was missing, make changes and improvements as necessary, get your bronze certificate. You move on to your silver award, which is multiple audits, and a whole lot more happens around that with RAG rating. One important part of this part is psychological support that is evident, and that's one of the key things for the silver award, which we all know is so important. And then there's a pre-assessment visit, and Bliss come out to do that. Then we have our gold accreditation. And then I said after that, we get our platinum accreditation after 3 years and the reassessment of the unit. It is a process, but as you can see, it's an audit process. So in terms of why units do this, obviously you can see there what kind of looking at the benefits of baby and family and benefits for the unit. And much of this looks like developmental care. And we're all familiar with these kind of things, and this looks very OT. So you can see how the kind of things we're looking at, enhancing bonding and parental confidence. We're looking at things like increasing breastfeeding rates and making positive memories. And for the unit, consistency of practice is really important. And we know that that can actually make or break a family's day or week or time that they actually spent on the NICU. And then looking at staff morale, and I think this is something which our nursing staff are under a lot of stress, and capacity is really challenging. So I think this is something that we'll be able to look out for, and this audit and accreditation, if done well, can really support that in terms of getting staff understanding how they can contribute and how to make a place a better place for everybody. Okay. So I said again, this is the kind of examples of what would happen on a unit improvement. So it might be equipment to support parental access. So you could have more reclining chairs, you could have breast pumps, you could have beds available, you could have a feeding room. You might be looking at more written material and technology for families. We might be looking at things like new services, and that might be having counsellors on site or psychological support. It might be things like we talked about before, having some wellbeing activities that are available. And then we've got more streamlined services. So there's a number of projects that have come out of that from different hospitals. So OT, first of all, just have a look if your unit's actually signed up and what level. That's a really good thing to remember. All these things that we're doing is that actually we're making sure that you're aware that these things exist and where is your unit in part of that, because what we want you to do is to feel like you can be a member of that team and to contribute for OT. And you can see from just those examples there how OT fits in quite nicely. Supporting developmental care, parent occupations, the parent voice and access are all key to the Bliss accreditation. So this is something to be really important that we can actually contribute our voice to, and the resources and audits. And you probably already have resources that you've made which might actually go a good way into actually helping them with their audits. So just understand it's there and find out from your unit if they're actually doing it and what level they're up to. Okay, last but not least, Baby Friendly Initiative, BFI, which I'm sure most of you will have heard of. It's a very well-respected program, and it's run by UNICEF and the World Health Organization, which aims to improve practice for infant feeding and healthcare setting. The idea here is that they aim to improve care on neonatal units, especially around skin-to-skin contact, expressing breast milk and breastfeeding for improved outcomes for the most vulnerable babies. It provides parents with the best possible care to build close and loving relationships with their baby and to feed their baby in ways that will support their optimal health and development. Now, the BFI is really stringent and amazing and rigorous. So I'll go through how that works for you. And you might have seen some of these pamphlets in your unit already or something very similar. They do put out these which we can actually utilize, and I'll go through a few of those in a minute. But BFI is in 3 stages. You have your audit stage, your interviews, and your observation of practice. It's led often by the lactation consultant or an infant feeding specialist or a speech and language therapist on your unit, but it does involve the entire MDT and unit because you get assessed by the people who come out to assess you from BFI, and they will actually be asking all staff the process as well as the parents of how things are going. The accreditation process looks similar to this. So the idea is that you actually move through stages of the accreditation. There's an audit tool initially to get started, and that uses interviews with clinical staff and parents, so you can map your process over time. And you go through you basically can apply for the 3 standards, stage 1, stage 2, and stage 3 of accreditation. There's project leaders, I think, are really important to have, and they have a project champion also, which tends to be, or project team leader, which tends to be a lead nurse or one of those clinical senior staff. And then they have a team of people, which can include dietetics, speech language, psychology, developmental care leads, OTs, people who are actually there, and generally, hopefully, someone from a neonatal peer support group as well. Okay, so this could go on for a number of years. I think that's what's important to remember about BFI. This is not a quick win. This is not going to happen in a month. This happens over a couple or 3 years. And as we go through, you can see there actually are a number of hospitals who actually have been doing really well, but only a few have actually achieved gold standard and a gold award. So if your hospital has done that, that's fairly amazing feat. But it is really important. So most hospitals will be on the process, and really good to find out where your hospital is in that sort of stage. Okay, so there are 3 stages. The first stage is around building a firm foundation. So this is all around actually getting guidelines and policies written, looking at education programs and making sure that staff are able to do the things they're supposed to do on this unit around these foundations. We're looking at having processes for implementing, auditing, and evaluating the standards. And the other, number 4, ensure there's no promotion of breast milk substitutes, bottles, teats, or dummies in any part of the facility or by any staff. That's quite an interesting stage, essentially, and it's assessed by reviewing all the documentation and their systems that gets taken to the BFI team, and they look at their data collection and curriculums and their plans for staff attendance. There's a whole bunch of things you have to go through with that one. When you reach stage 2, we're really talking about educating staff to implement these standards across the role and service providing. So that's about interviewing staff and asking them about their education and their knowledge base and how they support skills in breastfeeding, how they use pumps, how to do all those things. You get asked all those very strategic and very even specific questions to see if actually people know what they're doing. There's manager interviews, the project leads get interviewed, and they go through the training records. Stage 3 is around the parent experience, and this is around where they come out and interview the parents themselves to see how the parents have been supported in a close and loving relationship, to see how that people have been available to expressing for skin to skin, have they been able to hold their babies after feeds, and what the ongoing support has been provided for these families. This is an example of a standard 1, stage 3 checklist that they do, and it's around about looking at how what actually they're checking off, and as a unit how you can check off to see if you're actually doing these things. So it gives you a bit of an idea there of the kind of things they're looking for. You know, skin to skin is prevented only by acceptable clinical reasoning and not because of lack of staff, and we know that's really challenging. That skin to skin is encouraged and frequent and prolonged. that staff are unable to recognize the baby's behavioral cues and tolerance for stimulus, and parents are supported to build closer relationships. These are things which as OTs, we probably have the skills to do. And the question for us is, are we actually enabling our staff and our MDT colleagues to understand these things as well? So we have a significant role to play in this. Here's another one about the partners and parents as partners in care. So it's looking, can this parents, are they being able to be welcomed onto the unit? Do staff introduce themselves? Has the parent felt like they have 24-hour access if they want to? Have they been encouraged to comfort and support their babies during procedures? And we know that sometimes that literally just doesn't happen. In fact, they're discouraged. So this is a really interesting way of actually assessing how we're going as a unit. The nice thing about what they do for this is they actually give you a lot of resources. There's sample policies, there's curriculum developmental guidance, there's loads of resources to use like the written booklets and audit tools and courses and videos. There's online courses you can go and take in breastfeeding. There's ones you can go for 5 days with to help you implement it on your unit. They've got a lot of resources, and it's really worthwhile jumping on their website and having a look. I think what I like about this program is that even though it is rigorous, you are well supported. They're not leaving you out in the lurch. There's lots of things for you to actually help with that. But don't forget, it's unlikely you will be the person who will be coordinating it, but what a lovely opportunity to get in there and work with your fellow MDT to actually support this for your unit. So how does OT fit in? I think one of the key things is to know is a little bit about what early lactation is and what it looks like, and how to explain and teach things like hand expressing, setting up a breast pump. We often see them in the units, and sometimes we can say, oh, that's for the feeding team, or that's for the nurses to do, or that's for the speech and language therapist. But actually everyone needs to know how to do this. Certainly in my job, I've been actually asked before plenty of times that a breast pump hasn't worked or something like this, and having to know how to do it is really important. And you might find in your hospital, even if you're linked to the maternity ward, there might be things you can already go to for free to understand how to do this anyway. So ask around. If you're going on to as a new OT, or if you've been there for a while and not sure, just ask around in their maternity unit. Often they'll let you come and do that as well with their staff. Understand baby's feeding cues, and we're going to talk a little bit more about this when we have our away day and look at feeding as an occupation that we can be involved with, and how we look at the person and characteristics of that, and how that affects feeding. But it's a major occupational role. And I think as OTs, we do have a role to look at this, but actually knowing baby's feeding cues and when we're going to be doing this is a really important part to play. Looking at that, helping to remove responsive feeding. And we know responsive feeding is interesting because most of our babies won't get to fully responsive feeding by the time they go. They're quite little, but that process that goes from that baby who's on a tube feed all the way through to having breast or bottle is something I think is really important to remember. So knowing how we can actually feed back into that. And absolutely skin to skin policies and practices. So we're looking very much around how we're actually doing as a unit. You could do audits around this. I'm sure there are audits around it already. And then looking at how we can promote this specifically to support early breastfeeding development. So I guess in summary, this is a very whistle-stop tour from Bev and I of a whole lot of different ways you actually can see your unit doing in terms of frames of reference and things they're using. We hope this has helped you a little bit about getting some background to some of the terms you're going to be using. But in summary, we're looking at things that OTs can do. So first and foremost, find out what's happening in your unit already. Where are they in their BFI accreditation? Have they done Bliss? Are they doing FiCare? Is there a FiCare team? Is there NIDCAP trained nursing staff? Often there is. So find out who's on the ground and how you can be a part of that, and spend time with the MDT. And I can't stress this enough, and Bev will be the same. When we're looking at being OTs, we're a part of a much bigger family. So being able to be a part of that and knowing what our colleagues are doing and how we can support them as well is really important, and it will help them understand what we do. Consider how you can contribute, knowing what our skills are, and actually looking at how we see the family as both the parent and the infant, and how they are a dyad together, and how we can support that is really important. And we provide a lot of that evidence to prove how important it is for psychological support as well. one key we're going to say is don't overcommit. These are big projects. So, and you will have limited time. So this is a universal work much of the time, and that's a really important part of our role. But look at things how you can actually start to make either quick wins or things that you can get in 1 or 2 projects and actually do it really well, versus trying to get involved in lots of different types of things and feel like you're running and chasing your tail. Look at QI training and change management courses. This is what we're talking about often, and we're really looking at change management. So look what's on offer already in your trust. There is going to be things around, and if you need some extra support, I'm sure that we can help you with that. Change happens over time, guys, so be really patient. Your unit might be flourishing in one area and needs some help in another, and that's fine. Doing small things and doing them well is really important. And then, as I said before, getting involved with the wider MDT is really useful. And knowing who your change agents are. Who are those people who have buy-in? Who are those ones you know actually do have a voice that people can hear louder? I guess on the neonatal unit, it might be might be a team of nursing staff, it might be some consultants, it might be people outside of the unit. It might be the MDT AHP group. I'm not sure, but have a look in your unit and who can you get with. I mean, the best experience I've ever had in my projects that I've done for FiCare, for example, have when I've worked with a FiCare team, work with my nursing colleagues, and that's been amazing. And we've really been able to do some really great things because of our different skill sets. And firstly, and the last thing I want to say is model change well. And one thing I've really been encouraged recently to really look at is appreciative inquiry, which is a little bit different from going from a problem-based to what's going well scenario. So have a think about what is going well in your unit, what is working well, and feed that back to people already, because good practice promotes good practice. So I think that's something really important to remember when we're looking at this. We don't get too bogged down with what's not happening and how we've got so much to do. Look at what's already going on, because there'll be some lovely practice going on, and really highlight that. So then when it comes to making small changes, that people are more open to actually having that feedback. Rightio, we might have some time now. We're going to have some questions, and you guys can find out how we're going to go, and then we'll do some knowledge checks after that.
Thank you so much. Let me just bring you into view there. Thank you so much, Beverley and Amanda, for that really, really interesting presentation. You said at the beginning, or before we came on camera, that it was a bit of a dry subject, but actually it hasn't been, listening to you talking about how we as occupational therapists fit into these national frameworks and programs, and it provides us with an opportunity, it strikes me, to really showcase the role and value of occupational therapy. So I have got a couple of questions that I will ask you to in a moment, but I also invite if anybody else would like to pop something in the Q&A, you'll see the bottom, a button at the bottom of your form, so please do pop some questions in there if you have them. But before I get on to the questions, just a reminder that these webinars are being recorded, and the recordings will be made available on the RCOT website once we've done things like add transcripts and sort out a few other technical bits. The slides, the self-assessment quiz where you can check your knowledge, check your learning, and a feedback form will all be emailed out to participants, and we'll put the links to those documents. We'll upload those when we upload the video as well, so that you'll have those to follow up with. So all of that will be coming. So I know those are the burning questions usually. And just a reminder again that this is one of a series of webinars so all sorts of information that's coming out for occupational therapists working in neonatal care. So that's a bit of a summary dealing with some of the initial questions. Right. So on to the ones that I've written down here. I think it's really interesting that neonatal frameworks are being applied internationally, nationally. And I wondered what you think about the benefits that has for occupational therapists to have that international or national approach to the way that we're working in neonatal units. I'll leave you two to decide who's going to answer.
Amanda can start first. Go on.
I can start. I don't know. I think we have a lot to learn from all different cultures and aspects around, the world. I think, I'm an Aussie, so obviously I've got a different perspective from a different country too. I think when we're looking at frameworks and how we can learn from each other, I think what we're doing is we're all bringing a unique viewpoint as to how our systems work, and then how we can adapt to make the best possible outcomes for the families and parents and babies that we're actually seeing. I think there's a lot of history, there's a lot of backgrounds, there's a lot of people who are doing such great work globally, that if we can come and bring that to the UK specifically, then that's going to only benefit the families that we're going to see.
And I think the other aspect, particularly when we're thinking about developmental care, but FiCare is also another good one, and BFI, is that it is standardizing it's setting a standard of practice that everybody should follow. So for instance, developmental care in research is really poorly defined. Developmental care in one paper might mean that, they control sound and light, and in another it might be something like they're using NIDCAP based care for all babies. So I think having more agreed standards like the European ones, or thinking like FiCare and BFI, that it's making sure that everybody, if you do BFI in England, it's going to be exactly the same as if you do it in Wales, and it'll be exactly the same as if you do BFI in another country like Australia, or I'm Zimbabwean, so it would be similar there. So it does give that and it sort of crosses across. It gives that transferableness. So I think for OTs, often, Amanda and myself, we're not from the UK. We've come here, and it means though that it does give that shared language as well, which is very helpful.
And I guess there's also strength in numbers, isn't there? There aren't a huge number of occupational therapists working in neonatal care. So if we can make those connections across, the borders, wherever they may be, then we're adding to the body of knowledge, and that shared language, that shared understanding, that shared evidence base that is going to be strengthening the role of occupational therapy.
Absolutely.
We're doing actually here in the UK have already travelled overseas already, which is really lovely. So we are doing some great things from the UK going out too.
It also is quite useful because we are quite a small group, as you've said, Sally, but what we'll find is if you're thinking on your unit, you've been asked to do something for FiCare on something, it's worth using the neonatal forum and groups like that to check, because usually somebody else is working on a very similar project, and then we can have that. And as Amanda's talked so much about the networks, it's making sure that it's a network, because a network could be 27 units as in London, or it could be possibly 18 if you were in Yorkshire and Humber, but that means that you're once again having the projects that have an effect on more babies and families in units that possibly there isn't even an OT in, but that your work might be being used there as well, which is really helpful.
Absolutely wonderful. Absolutely. I wonder, sort of moving on from that, how does understanding these frameworks help us as occupational therapists sort of articulate our role and be part of the neonatal team? Often, I think you said right at the beginning, our time into neonatal units is often very limited. And it seems to me that understanding and being part of these frameworks opens opportunities for us to extend our reach, our skills and knowledge base beyond the 2 days a week that we might be there. What are your thoughts on that?
Oh, I think that's so true, Sally. When you go and you be able to spend time with your colleagues in an environment where you are doing joint projects, or saying, oh, you're doing BFI, do you know we contribute this way? Or we're doing FiCare, actually, we're really engaging with families and actually making them partners in the way we're actually using care. Those are the things that that often our colleagues just don't know. It's not that they don't want to have our involvement, they just don't know that that's what we do. And I think that's up to us to really not push and promote ourselves and go to the front. It's not about that. It's about being a team and saying, actually, I've got specialist skills in that, I'd love to help out. And I think when you've got those opportunities to do that, then staff understand, other staff, nursing staff, other AHP colleagues, potentially clinicians, they start to understand what you do, and then can actually explain it to families, and then families actually then get a better understanding of who we are. So when we approach, or they actually referrals change, and they do change for the better, but families can then have an understanding of how we can support them as well as part of the bigger team.
Yeah, I think I agree very much as well with the getting to know people that you might not be on the unit with all the time. Because if you have two very set in stone days, there'll be nurses and AHPs and doctors that you'll never see, that you might never get to know. And by being part of some of these projects, it means that you will be making those connections. And also for a lot of people who've never worked with a neonatal OT, when you say, oh, well, we actually do this, they're quite surprised, but then quite quickly you're asked to do more things. Or a family that, you know, really needs that help, you'll then get a referral or asked, please, could you go and see, you know, baby Jones and his mum, because she's really needs help with this or whatever. So I think it also just promotes the role in another way as well.
And you might already have projects you've been doing too that you might actually can take with you, that actually highlights what you're doing. So instead of actually sitting in the office and doing your project that doesn't get as much traction, you can take that with you and see the bigger picture. And we don't have to be the ones who implement everything. I think we think because we've got a program, we've got an idea that we have to be the implementers, but often we're not. Often we're the support to implement what's going on as well. And that's the universal role that we play as well. So I think that's a really important thing to remember, that you don't have to be everywhere all the time with everybody to have impact and to share our skill set.
And I think that reflects other areas of occupational therapy. You know, that there's certainly enough work to go round. There's too much. We can't be seeing everybody. You know, we don't have that capacity in most areas of practice, I would suggest. So our skills in sharing that knowledge and information, as you say, so that it can be implemented by other people, and then we get asked to see the ones that really need that. They need occupational therapists, but you're actually making a contribution to the culture and practice within the unit that's going to benefit way more infants and families than we could ever see individually. And it strikes me that that's a real value of understanding and working within the frameworks that you've described this afternoon. Okay, my next question. I think it's absolutely wonderful to hear how occupational therapists have been involved in, well, developing some of these frameworks that you described and promoting them. Oh, have you got any thoughts about how we can continue to influence or use our occupational therapy skills to influence the sort of adoption and spread of or implementation of these frameworks beyond the unit? I think you gave some hints there about being part of the ODN and other ways. Any more thoughts on that?
You go, Bev.
Well, I think what is very exciting is that a lot of people may know, but for England, there has been an investment in developing the workforce for AHPs across neonates, which includes OT, and this has been really exciting. Sadly, on the back of a very upsetting and sad maternity review, that we actually got some money to do this. But it's been such an exciting time to think about developing the workforce and spreading it out. And luckily, the English team aren't keeping it to ourselves. We're trying to spread it out across all the home countries, which is really helpful. And I also think that trying to think about other things that I think a lot of the OTs who work in neonates are involved in sort of bigger picture things. So it might be education projects, it might be incredible research. So actually it's touching more people. And I think as a group, we have a large place to play in that. So we might be doing teaching on a national level. It's not unusual in neonates. There are some of the top researchers in neonates across the world are actually occupational therapists. And when you read the research about pain and stress management and clustered cares, it's generally all OTs, which is, I think, is a testament to how we can do. So I think working at a network role, working across the country, but also then working across different units and even across different countries is something that's quite exciting for us as well.
Yeah, I'd love to see that. Wouldn't that be fantastic? Having sort of mentorships across the countries to hook up with other OTs in different areas would be amazing. And getting involved in it. I mean, there's things like NANT, which you can get involved in the US just to see what's happening over in there. There's a whole bunch of things that we can get involved with. But I think what Bev says, research is a really important one that I think we don't necessarily have the capacity. Sometimes we don't think we have the capacity to do that, but it's such an important role that we could be playing. So maybe looking out for those opportunities is really what we could be harnessing more.
And you talked about some of the change agent or change processes as being part of a leadership opportunity. And I think that came through quite clear, and we at RCOT would say that everybody is a leader. You know, whatever your level of practice as an occupational therapist, you are a leader. You're a leader by role modeling, by taking part in research, by sharing your understanding of the evidence base with not only occupational therapy colleagues, but the broader MDT. So I think that, again, provides real opportunities for us to extend our knowledge and skills beyond the unit. So, you know, getting involved in research projects as a participant, you know, if somebody's calling to understand people's experience of service delivery as an occupational therapist, then that is part of being a leader, showing the way, being a change agent too.
Yeah, I think we underestimate when you start to get involved in projects. We think they're going to be projects for your unit, but you just don't know where those projects are going to go. So you could start very small on the ground, and I was involved with one and it's still going, and we ended up having the research team, consultant, nursing staff, myself, a whole team of what we were actually making change for the unit, and we're hoping to write that up. So I think over time you can start to do that, and then you develop your own skills, like you said, Sally. I found out what the researchers are doing and how they're actually doing it, and to be able to contribute to those things. So yeah, it's important. Doesn't matter, you can start small, see what happens. Absolutely,
and understanding the frameworks, the delivery, the context in which services are delivered is a really important part of that. So a couple of other questions here. Have you got any suggestions, either of you, about how people might expand their understanding of, say, developmental care? Any resources that we should be signposting people to there?
There's so much now. I mean, I know when I started a long time ago, there were, I think, 2 neonatal books that mentioned occupational therapy, and they were generally the Americans, and then Betty Hutchin managed to get a chapter in a book, but now there is so much. So I think definitely the European standards, I think, is a really good place to start. I think there are courses available that give you the much more wider, broad understanding and evidence base as well. What else, Amanda, would you think about?
I think that there's a lot of online things which you can actually, get for free, and I'm probably not, in terms of actually accessing those, going through your neonatal forum that we actually have, you can get access to what courses are around and available, what we're actually doing on the ground here in the UK, and then what's going on overseas. There is a plethora of things you can start. The problem with neonates is not that there isn't out there, it's the fact that actually there's so much out there you can get lost in it. So, starting simple is really good, like we talked about FINE, and we've talked about other things like that on the ground, which are really good to do. But the neonatal forum will have information about how you can actually access different ones that are both UK and international.
And there are some things that I, for instance, follow. So on Facebook, the Australasian NIDCAP Training Centre is just incredible. They do something every day virtually. So they will give you a recent paper, and they'll give a little précis of it, but then you've got the paper, or they might do a video, an instructional video of how to do a sideline nappy change, or they produce a neurodevelopmental newsletter once a month. It's incredible, and this is all stuff that's for free. You just have to follow it on Facebook, and it's quite nice to get things like a paper, because already somebody's pointed you into what the key points are that you can look at. And things like on the FINE website, they've got a developmental care newsletter that also talks a lot about the latest research that has come up. Have a look as well. The other things that I've done more of in the last couple of years is look at BAPM events, look at the Royal College of Medicine events. I just recently went to the most fantastic webinar with Royal College of Medicine, I think it was, looking at stresses in pregnancy and the effect on the baby's outcomes and the child's outcomes. That was absolutely brilliant, and that was more perinatal, but of course they were talking about, so it's almost like an ACE, an adverse childhood event almost, but they were talking about the effect of severe stress in pregnancy and what that would mean. And when you look at the increased risks for the babies, it was all stuff that OTs are going to have to see those children at age 6, 7, 8, 9, 10 at school when they're not doing so well. So have a look around, because often these, you don't have to be a member, and it might be quite nominal. And I think the one thing COVID's been helpful is people have moved online. So things like this, like the webinars that you can go on, and it might be £10 to go on to a Royal College of Medicine webinar, but actually it's really brilliant. You then get the recordings and they send you the papers, so then you've got more to read about, and especially if it's an area of interest. So have a look around at all the things that related to children and to babies.
I think that's really great advice, and one message that I hope people take away from this is that it's not all about going on a course. There are a whole range of different learning opportunities to suit everybody's learning style and our ability to access training and support. So, developmental care is just one example of the different ways that you can access learning. And I would just reiterate the value of joining the Neonatal Clinical Forum, which is part of the specialist section, Children, Young People and Families, who run some wonderful learning events and sharing events where you can chat through things with clinical experts like the two that we've got in the virtual room here right now. So thank you. Okay, just another quick couple of, the comments more than anything else. We've had a couple of questions around transition and moving on. I'm not going to ask you to talk about that right now, because we are planning another learning resource opportunity, which is particularly going to be focusing on that. Maybe a webinar, maybe an e-learning module. So there will be something coming out in a little while that talks about the role of occupational therapy in facilitating that positive and successful moving on from the NICU. So watch this space for that one. We do have a question here around the operational delivery units have been putting in Band 8A level OTs. And any thoughts on how successful they've been about attracting resources and gaining consistency?
I think really successful. I mean, Amanda is working in Thames Valley and Wessex. I've just given up part of the post in London. I think that they've been really successful. It was an unknown entity. It was something very different. I don't think it's really happened in the same way in any other area of practice in sort of medicine. So it was an unusual thing. And I know people have been quite worried about the bandings. People have said, why is it an 8A? Why is it so important? It's a highly complex role because we're working with lots of units, but it's starting with that groundwork, isn't it, Amanda? It's making sure that a unit understands what a neonatal OT brings to the table. It's that education bit. It's helping create business plans. It's also getting units to think differently. So will an in-reach model work? If you've got a really good community pediatric team, could an in-reach model work? Thinking about making connections between units and therapists. So in the background, they're doing a huge amount of work and trying to provide equity, because it is such a postcode lottery, not just in an individual across the north-south divide, but actually in London, it's such a postcode lottery as to whether you're going to have access to an OT or a physio or a speech therapist or psychologist. So this is trying to develop that workforce. And I think there's been that initial input of money, which come through the Occupational review, and that has been phenomenal. But what it's also meant is, we're not sitting back. We've got staffing standards across neonatal OT and all the different professions, and it's saying to units, yes, you might have a little bit of investment now, but actually it's not enough, and trying to really promote what an OT would do. So those posts, I think, are key and just so exciting, and they're also a real good resource for you if you're trying to get into neonatal OT, or you're getting lots of referrals from your neonatal unit into your community service. Find out who your OD and OT is and start opening a conversation, seeing what's going on in the area, and bring your thoughts and concerns to them, because they're really useful people.
I think we're getting very creative in how we're doing it. So don't think, across units too, we're not thinking just that unit gets this much. We're thinking creatively in bigger picture, which I think is really important. And I think the biggest challenge is like, what is OT in neonates? But what a great opportunity to be able to say that on a wider forum across England. So it's been an amazing opportunity, and it's not without its challenges, but definitely positive. And there's definitely new positions that have been created. And the key that we're looking at now is how to support those really well. So
yeah, and that's the other big. Yeah, that's the other big part of it, has been looking at supervision and education strategy. So it's not just about people in post, because we could create posts, but then if they're not supported, they don't have access to supervision or to training. So there's, the ODNs together are creating supervision strategies. So the OTs. We've got a national across the UK supervision program that we've just started. So it's once a month, and it's hopefully going to be really useful. So it's also trying to plug some of those, identifying those gaps, and then plugging them to make sure that people aren't out there on their own, which is what we don't want.
Marvellous. Beverley and Amanda, thank you so much for your time this afternoon. Our time is just about up. Can you believe that? We could keep talking for ages and ages, I know. Really value you sharing your experience with us today. And just as a reminder, the webinar recordings will be available on the RCOT website before too long, so watch out for that. Keep in touch with the specialist section to find out about other resources and support. And if you are working in neonatal care currently, there will be 2 in-person workshops. The first one takes place on the 27th of February in London. The second one will be in Leeds in April, and you'll be able to book through the RCOT events page. So take a look there, and we look forward to seeing you again soon. Thank you, everybody, for your time this afternoon.
Thank you.
Thank you.